Thank you very much, Karen, and it's good to be with Sandra because we knew each other in the Capitol when we both worked there in the old days. And I worked there in the old days before term limits, and so I could aspire to work my entire life, perhaps, as an elected legislator if the voters approved. But then term limits came along, and I had to find other things to do. And so along the way, those two things just referenced include health and the health plans, and then the volunteer job, which is this state Delta Stewardship Council. It's an effort from 2009 for the legislature and the governor to have yet another coordinating body over the hundreds of organizations that have something to do with controlling water or affecting the Delta. And so, I do a little of that and work for the health plans. And it strikes me when I have a headache, I try and tune in, and it's either water policy because everything moves so slowly, and then I stop thinking about that and I move over and think about health policy, where everything moves so fast that it's hard to keep up and it's a constant effort to learn. And so I think the theme of what we are doing and what you will continue to do and we need to do as health plans and as the association representing health plans is learn from each other and learn from other sources, because things have changed. The common view in the public's mind probably still thinks of health plans as health insurance, and that historic model, which is somebody pays a premium, the individual or maybe your employer, and then in exchange for that, you pick a doctor or go to the pharmacy or have to go to the hospital, and you pay a share of that cost. Historically, the indemnity plans was the health insurer didn't care much where you went. It would pay 80%. You had to pay 20%, and that was, its own constraint, to be sure. But the evolution really was established in California in the 70s and 80s and on, and it was known as health maintenance organizations, or HMOs. And the most noteworthy one, and still the largest, is Kaiser. But the notion was, rather than paying most of the share of cost for something as if you were in an auto accident and you had to have your front end repaired, and so you pay 20% to the body shop and the insurance companies pays 80%, and there you go. The notion was that there was a prepayment, and individuals or businesses would make that prepayment, and then the state would oversee to make sure that the health plan would have adequate doctors, hospitals, medicines, and other medical services necessary to both deal with illness and injury, and also increasingly, as time went on, provide preventive care. That was the HMO model. It grew in California, it continues to grow, and it outstrips what happens in the country. And eventually now in California, virtually all forms of health insurance, PPO or HMO or even EPO, are a version of managing the care. But that can be a continuum too, and hide different types. It can be simply a health plan negotiates discounts because there's too many doctors or too many hospitals in a given area, so you can get a cut rate, and then that savings you can pass on to your customers, be they individuals or they are businesses. And then perhaps you can affect utilization by having someone, a primary care doctor or a gatekeeper to go through. And so over time, from the 70s and 80s, where cost control in California succeeded due to the HMO model, we got into the 90s where the backlash was that HMOs were in the business of saying no to save money or constraining your choices on who you went to. And so lots of changes and reforms occurred in the late 90s and continued into the 2000s to be sure. But much more changes, of course, occur with the Affordable Care Act, because now the view established in the ACA and reinforced in California law is that we need to look at the whole person, not just look at this set of medical needs where an employer can take as a rider mental health maybe, or leave it out. Or in the not very distant past, you could buy coverage that excluded maternity. Good for young guys, maybe not such good social policy, and not good for women. Made their costs much higher. And so health plans, health insurers, responding to employers and to individuals, sought to contain costs. But you seek to contain costs, it means potentially constraining services or giving people options. Well, the public policy changed. The public policy in the essential health benefits is broad-based and recognizes behavioral health as part of the whole person. And so clinicians and medical experts and plenty of research, and you in your lives and practices and responsibilities know that perhaps the best, realize that we have to look at this differently. And so with the ACA requiring plans to provide all these services, and in the Medi-Cal, both the two things, the expansion, the optional expansion that the federal law provided, where now adults not attached to children and not disabled and not aged could and would sign up for Medi-Cal, and the fact that mild and moderate mental health conditions are covered benefits through Medi-Cal managed care plans. From the health plan world, and we represent California Association of Health Plans, the commercials and the public plans, be they county-operated health systems or local initiatives. So all of those have to think about how we are going to do things differently. And in a world where value added matters, and it matters to health plans, what is it that we offer? Is it only the ability to do discounting? It's certainly not the ability to shop for your customers with pre-existing conditions analyzed, because that's prohibited. Take all comers. People like that in theory. It's very popular. The ACA, even among people who think they hate the ACA, like the notion that there's no medical underwriting. They don't realize, of course, that no medical underwriting means that the healthy people don't get a better deal than the sick people. Everybody gets the same price, so some people are going to pay more while others pay less. But that, of course, is relieved in the Affordable Care Act by those subsidies that happen through the exchange if your employer isn't providing your basic coverage. But in the area of mental health and substance abuse, we have a lot to learn because health plans are moving into an area often that they have not inhabited before. Contra Costa Health Plan has, and some others, but many have not. And so working with county mental health, where you have shared providers in the community that perhaps health plans can contract with, even as the county does, or relying on agreements and contracts with county mental health programs and behavioral health, so that you have a continuity, because the whole person doesn't just mean the body parts and the head and what's in the head, but of course it also means we change over time. We get better or we get worse in terms of given conditions and health. And consequently, the person who needs care at a mild level that is the responsibility of the health plan today may be the person that the county is responsible for tomorrow. And maybe sometimes it goes the other way. The person who has afforded himself or herself of county mental health services or substance abuse services, but previously didn't have medical coverage, now that loop can be closed and integrated. The undocumented remain sort of an asterisk and an exception to that rule and worthy of much attention. But for an awful lot of people, this is a great opportunity for the whole person to be covered. The challenge, of course, is who pays for this? In the Medi-Cal world, it is the state and federal government's responsibility. And so adequate rates that go from the state as it assigns the responsibility and transfers the risk must come to health plans, be they public health plans or those commercial health plans that are in the Medi-Cal counties. That rate then can be translated into sharing with counties or with the provider networks and individual providers that sometimes are in short supply, and in shorter supply because the compensation is so low. Health plans have often relied on capitation. That is, for a set amount of money, you take care of this person per member per month, this dollar amount, and you figure it out. That avoids the perverse incentive often of fee-for-service that more visits and more treatment automatically leads to better health care. The only thing it automatically leads to is higher cost. Witness Medicare. So instead, health plans have relied on capitation. But this is more complicated, far more difficult, and not workable in some cases in mental health and behavioral health. And so we need to learn from the counties and from the providers and from the clinics who many times have already, and increasingly plans need to rely on, integrated or co-located services for mental health with medical services, so that the federally qualified health center that can offer all of the services in mental health it is a benefit to the individual and to the coordination of care. And that coordination of care, not separately budgeted for typically, is something that together we have to figure out the costs, the plans and the counties as well. Because figuring that out and having good electronic medical records or co-location is a way to avoid, hopefully, the kind of prescription drug errors that occur when you have medical providers writing one script and a psychiatrist doing something else. these are all areas that we have to work on and work on from the health plan side, because our value added as health plans will be, as we move into this new era, is helping the providers of care coordinate it and have reliable, predictable resources to do so. And health plans need to hold everybody accountable for that, but that accountability goal ought to be the betterment of the whole person as opposed to only a narrow focus on either a body part, a psychiatric condition, or a cost saving. Thank you very much.
You mentioned that and I'm not even going to say what year it was a while ago that I was working as a consultant for the Health Committee in the Assembly, and Patrick Johnston was a member of that committee at the time. The good old days, I guess you could say. So let me just share a few thoughts as we move into our next panel about some of the reasons that, from the behavioral health perspective, we feel so strongly about working on integrated care and working with health plans and health providers. We learned probably about 7 or so years ago now that from research that took place all across the nation, that people with serious mental illnesses were dying 25 years before the rest of the population. Now, that's not new to the behavioral health people in the room, but it may be new to some of the health folks. And the reason they were dying was not because of their mental health condition as much as it was other kinds of health conditions that were not being treated. So it kind of woke us up very quickly to the fact that we were so focused on the mental health or the substance use condition or co-occurring condition of those two that we weren't even thinking about the person's other health care needs. So that really put us on a mission to figure out what we could do about that. Then the state of Washington looked at this a little further, and they added, well, if you added substance use conditions onto the mental health condition, what happened? Well, the person lost an additional 5 years of life. So now we're talking about people dying in about their late 40s, which was pretty scary, particularly when we realized it was because of all these various health conditions that weren't being treated. Then I'm not going to mention their name, but unless they want to say it, but there's one very large county in Southern California that took a look at their population, who they were treating, to figure out what was happening in terms of their average length of life. And they found that their folks were dying on average at 41.8 years of age. So that county is one of our best counties in the state right now in terms of integrated care. So a couple of other things I just want to share with you. Most people are aware of the fact that in a Medicaid population, about 5% of the population drives about 50% of the cost. And most of those people are people with multiple chronic conditions. What not everybody is aware of is that when you look at the pairs of the top conditions that create this excessive cost, the top 5 pairs, of the top 5, 3 of those contain a psychiatric condition. And in fact, the most costly one, which is psychiatric conditions and cardiovascular, and the second most costly condition, which is psychiatric and central nervous system disorders. So when you look at that, and you look at the cost that's being driven, which doesn't even tell you about the awful health outcomes for these folks, then you start to pay attention a little bit more. I found when I talk with policymakers, I can talk about health outcomes till I'm blue in the face, and they nod. They think it's important. But when I mention the bottom line, boy, I've got everybody's attention. So I just think it's important to remember that. The other thing I want to share with you about substance use conditions is Kaiser North, which is one of our neighbors here, did some very extensive studies looking at what was driving up their costs. And when they looked at it very closely, they saw that what was driving their costs, particularly emergency room use and hospital use, was substance use conditions. And these substance use conditions were impacting other health conditions in very negative sorts of ways. So they tried a number of experiments. They tried, well, let's see, we have a substance use treatment center, so we'll send people there as well as get their health care. And then we're also going to try one where we integrate the care. And what they found is that when they integrated the care, not only did the health of the individual person improve, but their whole family's health care improved. And it dropped their health care costs down to about the average. So I think when you look at those kinds of things and just think about what a difference it made for that whole family in terms of being able to address the substance use condition, it tells you why integration is so incredibly important for people and for, frankly, we need to get a hold of the cost of this system or it's going to drive us all out of business. So I think that integrated care is probably one of the most important things we can focus on. At CIMH, we're very focused on integrated care. We're doing a huge amount of work in this area. And we're hoping that this conference will help to inform us more as we move forward in this work so that we're really addressing the concerns that you all have. And you'll find we're going to put you to work very, very soon because we really need your help to help us think about how we're going to do this better. And I should mention before I stop that the California Institute for Mental Health recently merged with the Alcohol and Drug Policy Institute. So as of July 1st, we're going to have a new name, and that's the California Institute for Behavioral Health Solutions. So for CIBHS, thank you.